So this patient is going to get a Restore 2.5 IOL. I'm marking the axis of 10 degrees, which is where she has about a diopter of cylinder. So our plan is to do a penetrating limbo relaxing incision at that axis, actually two of them, one on each side. Now you can see that those marks are a little superior, but so I'll just do the LRIs parallel to them, a little bit inferior. Okay? So the patient's sensitive to fluid on the eye. So what I typically do is I just do it multiple times, letting them get used to that sensation. And that's what I've done here. And now she doesn't really squeeze anymore when the fluid comes on, because what's the point? It's only water, and you learn that it doesn't matter when you get it repeated multiple times. All right, so we're going to make the side port incision, typical technique, side port blade pointing upward. So if she gets a Bell's phenomenon, nothing bad will happen, meaning she can't extend this incision. Now, you can see the globes moving when I go to do that. Why is that? Because this blade is not very sharp for whatever reason. What do? You either fixate the globe like this and enter, or you get another blade. Okay, so we're going to make penetrating limbo relaxing incisions, one here and one on the other side below that one. So that just kind of works out nicely for where our cataract primary incision, namely our clear corneal incision. Now, so that's a 2.4. Eventually we'll enlarge it to 2.75 because of the nomogram for the amount of astigmatism. A little sting here for a few seconds. And we'll put the penetrating limbo relaxing incision nomogram. You'll be able to see it here on this edition of Mackool Online. The horizontal and vertical one, because it's different for the amount of astigmatism that you want to get, whether you do horizontal or vertical. And here comes our puncture capsule. And that's basically because of posterior corneal curvature that it's different for horizontal and vertical. But you'll see you actually, it appears that the nomogram gives you a greater effect when you do it vertically, but the truth is that the posterior corneal curvature in most patients, as you know from the Koch-Baylor nomogram, actually results in a different astigmatism than the anterior cornea would lead you to believe. Okay, so here we go. This is a flat 23 gauge hydrodissection cannula. We're going to just place it underneath the anterior capsule, lift up, irrigate, wide flow of fluid back there. You could see that fluid wave. Do the same thing on the other side, push it back down again. We now have a loose nucleus. Visco dissection, 180 degrees is all we need here. Now we've got a nice space between the capsule and one's cortex for our chopper. And just as importantly, if not more so, we have a dispersive viscoelastic out into the capsular fornix, which is a good place for it. Tends to keep capsular fornix where capsular fornix belongs. Okay, so now I've just no-touch technique, and I had to pop in there, so I raised IOP, because I use a tight side port, so it's a little hard to put the big ball chopper through it unless the IOP is firm. That's why I go to position 1 and then give it a quick little pop, and that time I had to try it twice before I got in. See the Y suture there? Can't miss it, right? So, is the Y suture deep enough to chop? Nope. Not in most cases. I mean, I could do it, but not as well as if I go through the Y suture carefully and get a little better red reflex below that Y suture. Now I know I can chop. Quadrant removal. Good. So, chopping technique. Chopper against sculpted wall, hugs it, goes up over it, and you bring it back toward the phaco tip. That way you never commit the pardonable but barely so sin of placing the chopper on top of the lens capsule You know, if I just went out there like that, let me just go out there. Now I might be on top of the capsule. But if I do the hug maneuver, as I call it there, right, then I can't be on top of the capsule. Okay. So now we're at quadrant removal. That was quadrant aspiration, really. If you use high vacuum, a lot of times you just don't need a lot of ultrasound. And a lot of times you don't need any. But it's a slower procedure. Now see, this would deform and go into the tip eventually at 600 or 700 millimeters of vacuum if I assist it like that. But do you really need to do that? Does a minimal application of ultrasound matter? Like that, and that, and that? And the answer is no. Really, the endothelium doesn't get affected by those short little bursts. But sitting on the pedal and delivering large amounts of continuous ultrasound, what the cornea, please? That's a no-no. So as soon as I hear that vacuum level go up, here I just aspirated all that stuff because it was going in. But I won't step on the pedal typically until I hear a nice high tone. And then I do it just momentarily, and I keep moving this phaco tip in a circle so that I attract stuff from different directions. And that pretty much is the basic, maybe more than basic, but very efficient, in my opinion, technique of removing a nucleus with an ultrasonic instrument. Just as I checked infusion with the phaco instrument, the ultrasonic handpiece, before I went in, I'd always do the same for INA. Grab that little piece of epinucleus. Okay, so now I really like to keep two instruments in the eye. I can position it. If the patient starts to move, I can rotate the globe. I can prevent it. It's just less reliance on some variables that you don't have control over. And then, of course, that spatula is terrific to protect the posterior capsule. Just like that. Put it down there. It's a blunt instrument. It's on the opposite side of the Mackool big ball chopper, so it's a dual instrument. And this 90-degree INA tip just lets you flip it around and take out subincisional cortex very safely. The spatula's there protecting. Big safety margin with that technique. And this is just removing epithelial cells from under the anterior capsule. Eliminates both chances of phimosis of the capsule and also adhesion of the capsule to the lens optic is prevented for months. We published our results with that. So if you have that exchange in IOL, patient's not happy, refractive, whatever, it's so much easier to do it. And because that gives you a nice area where you can go do viscodissection. Yeah, see the patient kind of move a little bit there. Why that was, I don't know, but we're going to find out. So let's ask her. So you just moved a little bit. How come?
I guess I wasn't comfortable.
Did you wake up or were you sleeping?
No.
Were you not listening to me, the greatest sin of all?
You.
You were listening.
Yes.
Okay. So nice and still. Nothing hurt you though, right?
No.
Okay. So, you know, I was only in the instrument in the eye with one cannula at that time, and it didn't matter, right? But most of the time I'm in with two, so that kind of move, I can hold the globe still much better. Okay, you might feel a little pressure. They normally don't, by the way, but I tell them all that as the implant goes in, so they're kind of aware of it, because I'm going to actually depress the globe, and that's what they can feel is a little pressure. So if you warn them in advance, then they tend not to jump. And there goes the IOL into the eye, and we're going to leave it horizontal. And now we're ready to do the enlargement of that incision from 2.4 to 2.75. This is the first of our PLRIs, if you will, and you do that by just side to side. See that motion? So you don't make a new pass and then wiggle to get in, nice and slow. Good. And that way you won't have multiple passes, incisions there that won't seal post-op. And now the first thing I'm going to do is the PLRI on the other side. Globe's full of OVD. IOP is very high because I'm on position 1. And I'm just going to make a clear corneal incision right there, just opposite the other one. And I don't want it too short because I want it to self-seal, but it will. And I'm going to make it about 1.5 to 2 millimeters long. Then I'm going to wiggle to get in slowly. You'll see OVD come out, and I back out. And there you go. So that typically will, those 2 incisions will get that diopter of cylinder that we want to get as we attempt to get this patient as spectacle independent as possible with a combination of the Restore 2.5 and the penetrating limbo relaxing incisions. I'm going to leave that IOL horizontal like that. Good. Syringe BSS. At the end here, we'll do testing with Weck cells to show that these incisions are sealed. That one's sealed already. I mean, those things, when you just...
into my ear.
You're getting a little water in your ear?
Yeah.
Yeah, it won't hurt anything. But yeah, it's okay. We're almost done, and I'm going to take the covers off you in a minute, and then we'll dry your ear.
Okay, thank you.
It's fine. The globe is really firm. Loose glove lets me palpate it easily. I'm going to put the vancomycin in. Let a little fluid out. Put the vancomycin in. IOP, probably at least 30, maybe a little higher than that even. Is that dangerous to leave them in the 30 to 40 range? Of course not. I mean, if they had advanced glaucoma or something, but in 5 minutes or less. So there's that one is totally sealed, nothing coming out of there. And that one's sealed, dry as a bone there. And now the puncture, that's the one, the side port, that tends to leak actually the most in my experience, but this one's sealed nicely. So we're done, all finished.